This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker this evening, we'd like to give you an overview of our free programs for those attending for the first time. So we'll go over who we are, what is our program, our newest program we want to discuss, and also introduce our speaker and then go through a Q&A. So again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter Deanna, who is also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with hypermobile EDS in 2008, the same year my wife Carol passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We have been the sponsor for these conferences for over 6 years. We started over 115 support groups to date, and each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We receive feedback. We typically meet each month at 7:30 p.m. Eastern Daylight Time. All of these programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for future replay. You can receive email announcements for future sessions by requesting the free guide on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. Proceeds from our stores and donations to our nonprofit organization help fund our programs. Please visit our store and check out the helpful products that we offer. Just a general disclaimer, this program contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment.
And our Physician CME educational program was launched in September 2017. It provides free continuing education credits that physicians need to renew their licenses. It is receiving an overwhelming response from the medical community. It is the first online EDS course providing CME credits. It covers diagnosis, classification, and treatment of Ehlers-Danlos syndromes and associated conditions. And any healthcare providers who are interested in learning more about EDS are encouraged to view the presentations, whether or not they desire the CMEs. As a patient, you have the opportunity to make a difference and improve awareness and understanding of EDS by encouraging your physicians and healthcare providers to participate. You may provide them with the website address here, Ehlers-Danlos-CME.org, and also print brochures which are available there. So you can go to the top menu at that website and click the brochure button, which is located all the way to the right. There you can download or print them yourself and take them to your doctor's appointments. There is also an option to easily order multiple color copies through a VistaPrint link we've provided, which gives you a 20% off discount for their printing services. And you'll find that all at the website for the CME program. Now, if you'd like to watch the webinar that provides more details about the CME program, you can go to our website, edsawareness.com or chronicpainpartners.com for more details about that. And we want to remind you to view our upcoming webinar speakers. Please visit the webinars page at edsawareness.com for the full schedule. And for those attending live, there will be an opportunity for Q&A after the presentation. Please add your questions at any time by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. So now for our speaker this evening, we're pleased to announce Dr. Jordan Tishler, who will be discussing medical cannabis. And he is a graduate of both Harvard College and Harvard Medical School, and also trained at Brigham and Women's Hospital. And he spent many years working with the underserved, particularly with our veterans. Dr. Tishler is also president of the Association of Cannabis Specialists. He's a treasurer and board of directors member of the Doctors for Cannabis Regulation. And he is a frequent speaker and author on a variety of topics related to the medical applications of cannabis. So we're really excited to have him join us this evening. And Dr. Tishler, a warm welcome to you, and I'm going to go ahead and hand over the microphone to you now to begin your presentation.
Awesome. Thank you. Thank you for having me. And I very much appreciate all the effort that you and John are making on behalf of EDS patients. Welcome to all the people who are listening. Thank you for coming and spending part of your evening with me here. Now, let's see, where are the buttons? All right, first technical problem of the evening. That's much better, guys. Thank you. All right, so we're going to talk about medical cannabis this evening, and the title here of looking at this, particularly in relation to pain relief and EDS, is really only going to be a subsection of what we're going to talk about this evening because, of course, as you all know, pain relief is sort of part and parcel of this, but it's certainly not the full story, and there are many other aspects related to both cannabis as medicine and EDS as an illness that cannabis can address, and we will kind of take a peek at some of all of that. So you've heard a little intro about me. I want to walk through my intro just a little bit further, only because I think it's helpful for you guys to kind of understand where I'm coming from, and that will kind of inform where, how you understand what I'm telling you. So yes, I went to Harvard Medical School, feels like ancient history, trained in internal medicine at the Brigham and Women's Hospital, but sort of more germane was that I spent most of my career as an emergency room physician and spent 15 years doing that at the VA. And it really was in the process of treating veterans for years and years that I noted that so many of our veterans were really harmed by various substances, and alcohol was certainly the number one substance, but then to a lesser degree various prescription and illicit drugs as well. And over the course of my career there, I really sort of got to be a bit of an expert on treating these substance issues. So then what happened was in early 2011, Massachusetts started pushing forward this ballot initiative to bring in medical cannabis. And I sort of had one of those aha moments in which I said, gee, I've seen all these guys who've been so thoroughly harmed by all these substances, and yet I've never seen anybody sick from cannabis. So if we're thinking maybe this stuff could actually be useful as a medicine, and I'm not seeing the result of the, horrible boogeymen, from how bad this stuff is, maybe I should look into it. And that led me to sort of dive into the medical literature over a period of a couple of years, going in with the kind of skepticism that one might expect from a physician, but emerging on the other side being remarkably convinced that, first of all, there is a lot of data on cannabis. Not all of it is great data, but there's really enough there that we can make responsible choices based on where we are today. And that, in fact, under the right circumstances, with the right approach to illness and to dosing and attention to patient care, that cannabis can, in fact, be a very useful medication. And then what happened was that I sort of looked around at the lay of the land and said, I don't think very many of my fellow physicians know much about this, which really isn't so surprising, and much of it is because of the illegality, and part of it is also because, we're talking about a non-FDA approved botanical. But I looked at that and said, how do I make this work for people? I looked at the VA, and that was clearly a non-starter. It's a federal institution, but what's really interesting is that when you look at large private institutions like the Mass General or the Brigham and Women's Hospital, you realize that they're over a barrel because a vast amount of their funding comes through the federal government, both in terms of Medicare payments, NIH support for residency salaries, and of course NIH support for all of the research that they do. So they were setting policies that said, look, we can't touch this. And so in thinking about how this was going to work, I said, I never set out to be in a private practice, but this would be a way for me to be outside the rules of these systems. But of course, I know all of the people who are the players in these various systems, so I will set up my practice outside and then go in and give talks, much like what we're doing this evening, and show them the data that we have and point out to them that they know me and that I haven't flipped my lid. And what was really interesting about all of that was that I expected, as one might, a fair amount of resistance, and I was met with almost none of it. My colleagues have almost universally been very excited, very enthusiastic, and very curious, and also, interestingly, very much relieved by the idea that they didn't have to take this on, that in their 15 minutes with their patients, which is already sort of oversubscribed, that they weren't supposed to somehow shoehorn all of this together, but rather they needed to know enough to know when to refer patients to me or somebody like me, and really tried to establish this as a specialty model where we co-manage patients, and that allows sort of the best possible set of outcomes. I must apologize. Shortly before the webinar began, I immediately started to have the sniffles, so you may hear a little bit of that, and hopefully over the webinar it's not too gross. This slide's really about a little bit of history of how we ended up where we are. You probably have heard that cannabis has been used for thousands of years, and that is true, sort of. Cannabis obviously has been around for tens, if not hundreds of thousands of years, and human beings have certainly used this in one form or another for many thousands of years. We have evidence dating back to the ancient Chinese and to the ancient Egyptians and to some of the Eastern European tribes that have shown various applications of cannabis, either as a smoked leaf, but more typically using seeds and such like that. The evidence that we have is a little unclear whether this was used in a medicinal fashion, a ritual fashion, or a recreational fashion, but probably the answer is something that's a little bit of all of the above. One of the things I find a little interesting about the statement that cannabis has been used for thousands of years is it sort of is used as a statement to lend credence to how benign cannabis is. And on the one hand, I think that it's fairly reasonable to assume that if cannabis were, deeply poisonous, like, an amanita mushroom, we would have sort of the collective wisdom to avoid it. And that's clearly not the case. On the other hand, I would point out that cannabis, at least in Western medicine, has not really been a prominent feature until the beginning of the 1830s, and then obviously went out of fashion in the early part of last century as well. Cannabis was introduced in the 1830s by an Irish physician who had been posted to India, where cannabis was used in a more medicinal fashion, and he brought cannabis back to Britain in that 1830 range, and it was used for a good long time, and sort of started to fall out of favor a little bit in the late 1800s, particularly after the U.S. Civil War, when the hypodermic needle was invented, and where water-soluble solutions like morphine became sort of more important because they could be administered to people who were ill enough that they couldn't take cannabis, which is not something you can inject. It did, however, become actually illegal in 1937, subject to what was called the Marijuana Tax Act, and basically this was a political issue, had nothing to do with cannabis as medicine. It was all about the fact that there were a number of law enforcement agencies that were looking for business at the end of alcohol prohibition, and making cannabis prohibition a particularly successful idea because it was at that time more commonly used by people of color. At that time, there was a large push to demonize Mexican immigrants, and there were also some financial interests in protecting paper hardwood forests that the land barons owned against the simple and cheap and easy to grow hemp fiber. The FDA only became involved in 1970. The previous prohibition was about cannabis and hemp as a commodity. In the 1969, Timothy really took a case to the Supreme Court and won, invalidating the Marijuana Tax Act of 37. But within 2 months, Richard Nixon had installed the Controlled Substances Act, which is what we live with today, and unceremoniously have plunked cannabis and LSD into Schedule 1 with a bunch of other potentially dangerous agents with no reference to science and with no particular evidence that either LSD or cannabis were actually dangerous. As we talked about, there is this mantra out there that we don't have enough science to really address the issue of the safety and efficacy of cannabis, and frankly, I would like to call BS on that. We have presently more than 26,000 studies on cannabis, and quite frankly, that makes cannabis one of the most widely studied substances ever. It is also true that of that 26,000 studies, not all of them are very good, in large part because the federal government has stood in the way of getting good studies, but also because a lot of those studies that were funded by the federal government were commissioned to find harms, and some of them reported some harms and others of them reported not finding the harms. But the point is that there is a lot of data out there. There is no question in my mind that we can always use more data. I mean, who would turn down more good data, right? And certainly we see there are disciplines of medicine like cardiology where we have we have a rich and deep bed of knowledge, and we still continue to do studies and accrue more data. So more data is a no-brainer, but it doesn't mean that we are at a point now where we don't have enough data to make meaningful, thoughtful decisions with a perfectly understood rationale that we will refine our understanding as we get more information. The point being is that I think we can make good medical decisions now, knowing that we're going to change them later. I think a very interesting little point on the history side of things is that in 2012, a study from the United Kingdom stratified the substances that are on their Controlled Substances Act So they have one, we have one. Theirs is based on ours. And so they went through and looked at all those substances, and they tried to actually rank them based on that data and where they actually fell in terms of risk. And what was interesting was that cannabis fell far below both alcohol and tobacco, which, as we know, are relatively freely available in our society. Now, this is my scary slide. Do not get scared. The point of the picture on the left side of things is mostly to impress you, not necessarily to inform you. So let me walk you through it a little bit. But the bottom line here is that we have a system in our bodies, both in our brains and in our bodies itself, called the endocannabinoid system. And what this is the system that controls all the other systems. So people talk about its role as maintaining homeostasis. Homeostasis is a balanced condition where we are sort of biologically at peace and things are working well and our systems are functioning properly. And the idea here is that each of these systems has a job to do, but the endocannabinoid system is one, if not the major, system that kind of talks between all of these other systems and kind of keeps them doing the right things together. And again, the point of all of this is that we have such a system and that we actually know a fair amount about it. We have much more to learn about it, don't get me wrong, but the scary picture is the depiction of some of this pathway. And it ties into many other pathways that we know a lot about in terms of the inflammatory system and the immune system and such like that. So when we use cannabinoids, medicines from cannabis, or phytocannabinoids, meaning from the plant cannabis, we are using outside substances to influence this internal system. This internal system has multiple complex signaling pathways. It has receptors called the CB1 and CB2 receptors. No points, I guess, given to the authors on their imagination in the naming of those. There are other receptors that react to cannabinoids that are not specifically or solely involved in the endocannabinoid system, like the TRPV1 system, and there are a bunch of others that are sort of labeled down here at the bottom in that sort of brownish line. Then there are a number of ways in which the system works that have nothing to do with receptors, but rather have to do with the chemical pathways that are in that sort of lighter brown box in the middle of the page there. And these are important because this is where we can introduce chemicals in addition to the THC, which is the thing that binds the receptors, like CBD, which we'll talk about more later, that influence not only the receptors but also some of these internal synthesis and degradation pathways. Where am I going with all this? What I really want to impress upon you is that this is the reason that the phytocannabinoids work for us and that we're using them in a deliberate manner, in a deliberately and well-described system. And people often start saying things in the cannabis world like we should regulate cannabis like alcohol. And I actually find that to be very short-sighted because, in fact, alcohol really doesn't have any medical use, at least in modern medicine. Alcohol is a byproduct of yeast fermentation, which is a long-winded way of saying that it's yeast poop, right? And generally speaking, we acknowledge that poop isn't something that we want to ingest. Now, it turns out that alcohol, as such, is a poison. And if you drink enough of it, it'll kill you. In very small quantities, we humans tend to find it somewhat enjoyable, or at least some of us do. But the idea that the phytocannabinoids in alcohol have any analogy, either in terms of their biological function or our use of them for medicine, is really not a very good comparison. And so when people start talking about regulating cannabis like alcohol, I tend to say, no, let's regulate it like Advil, mostly for alliterative purposes. But the idea is that we probably need some sort of a system that allows for careful controlled use as well as some over-the-counter type use. So let's talk a little bit about some of the concerns that people typically voice. So the first tends to be, isn't addictive? And the answer to that, of course, is slightly complicated. The first part of that discussion becomes we need to remember that addiction and dependence are not necessarily the same thing. Dependence is a biological need for a substance such that that substance bodies become irritated and annoyed with us and let us know. In the air, food, or at least in order to survive, and if we don't get them, we are in trouble. There are some other examples like the SSRIs where maybe we don't need them quite as much in the same way anyway as food and air, but the point is that they provide us medical benefit and that if we stop them, we have a consequence of that withdrawal. That is distinct from addiction, which is not really a physiologic commentary, but rather a commentary on behaviors. That is to say, an addiction is a dependence on a substance that then spills over into a harmful set of behaviors that adversely affect the user and the people around them. And so we see in addictions people getting into trouble with the law or the destruction of key relationships and that sort of thing. So again, the question is, what do we actually see with cannabis? And the answer here is yes, we can see in small amounts some physical dependence on the substance itself. We'll talk a little bit more about that in a second. But what we don't typically is actually really that addiction or those massive. So whereas, in alcoholism, sometimes we see spousal abuse. With the opiates, we sometimes see, criminal behavior like robbing liquor stores to pay for the substances. We don't seem to see that in the cannabis community. Whenever we start to talk about risk, it's helpful to ask what are those risks, and so here we get to this line toward the bottom. The lifetime risk of dependence for cannabis is actually lower than the 9% that's listed there. Our best estimates at this point are closer to 7%. And we can compare that to a 32% for nicotine, which is, to our knowledge at the moment, the most dependence-forming substance, 23% for opioids, 17% for cocaine, also about 17 to 18% for benzodiazepines, which didn't make it on the slide, and about 15% for alcohol. So you can see that the lowest one on the list, other than cannabis, is alcohol, and that's roughly twice the risk of from cannabis. The other thing that's interesting to note about this is that the lifetime risk for the non-cannabis substances is constant, meaning if you are 25 years old or 85 years old, your risk from opiates is roughly the same, 23-25%. Whereas it turns out that with cannabis, much of that risk is front-loaded, meaning that if you are 16, 17, or 18 years old, then your risk tends to be more like 18%. But once you cross over the age of 25, your risk drops to about 2 to 3%, which leads us in many circles to have the discussion about, restricting cannabis in certain age groups, and there may be some validity to that discussion. The other thing that's not on this slide, but is something that's really crucial for us to discuss, is these are about the risk of having a problem. But then the other question is, what are the consequences of that problem? Really, what is the problem, right? So we know, for example, that that withdrawal from opiates is a very unpleasant process, right? Characterized by sort of 7 to 10 days of sweating, nausea, vomiting, intense pain, wishing you were dead, that sort of thing. And that's horrible experience, right? Cold turkey from opiates is very, very unpleasant. Interestingly, however, it won't kill you. Whereas withdrawal from the benzodiazepines actually can cause seizures and death. So in some ways, the benzodiazepine withdrawal is actually potentially worse. Now, if we want to contrast that with the experience for cannabis withdrawal, we're typically talking about sort of 3 to 7 days of insomnia and general irritability, which I'm sure is unpleasant to endure both for the individual and for the people around them, but it doesn't have quite the magnitude of consequence as we just mentioned for the opiates or for the benzos. Now we can talk a little bit about symptoms that are well treated with cannabis. And, number one on this list is pain. And certainly this applies across the board when we're talking about EDS and other connective tissue disorders. Number one, pain is the number one complaint that Americans come to the doctor for. It also turns out that it is the number one thing that patients tell us we're not doing a very good job with. And when we stop to think about it, it's not really such a surprise. The truth is that when it comes to pain treatment, we don't have a lot of options, right? There are really only 3 options. Right? We've got Tylenol, which falls into a category of its own, and Tylenol is relatively safe at certain doses, and it works for certain things and for certain people. The next alternative are what we call non-steroidal anti-inflammatories, which include things like ibuprofen and naproxen and such like that. And again, for certain things and certain people, those can be effective. But, between those 2 classes that I just mentioned, there are plenty of times when they don't work and plenty of people for whom they're contraindicated. And then you're very quickly into the third category, which is opiates, right? And where we don't really want to be because we know that opiates aren't so good for you. So then we can start to talk about where cannabis fits into this. And it turns out that when we're talking about chronic pain, which is defined as pain greater than 3 months in duration, it turns out that the opiates aren't very good. Not only are they dangerous, but they're just not very effective. Cannabis, on the other hand, isn't really any better, it turns out. When you put them head to head, cannabis is just about as good as the opiates are. But on the other hand, they're infinitely safer. So to my way of thinking, if you have 2 items that are sort of equally effective, neither of them being great, but they're both there, but one is dangerous and the other is safer, which one should you choose? And frankly, I think that's a no-brainer. And I'm pushing the wrong button. Anxiety and depression is another thing that we can address with cannabis. Certainly we see this a lot again in the connective tissue disorder community. And it turns out that cannabis can be very helpful for both anxiety and depression, but it also requires doing it in a very careful and precise manner. More so than many other areas, a little is helpful and a lot can actually be harmful. What we know is that in very small doses, cannabis can be used as an antidepressant. It's a fairly weak antidepressant, so that if somebody comes to me and says, I have ongoing depression, but I haven't yet needed any medication for it, then cannabis might be a reasonable first line medication. If they come in and they say, look, I'm taking a small starting dose of an antidepressant like sertraline, and I'd like to come off that and use cannabis instead. I think that that's not an unreasonable swap. But if people come in and say, Doc, I'm on a higher dose of an SSRI, 50 or 100 of sertraline, for example, then cannabis is not going to cut it. And so that's not a one-to-one trade. But the thing that's interesting to me about all of that is that while the SSRIs can actually be very helpful for many people, people are often put off by some of the side effects, and that's true with all medicines. One of the major complaints is this feeling that while the lows of the depression are better on the SSRI, that in fact some of the joy in life gets squashed by that, by the medicine as well, and people talk about feeling like a zombie. And obviously that's unfortunate. You certainly would prefer not to come out of the pit just to feel like a zombie. But what's interesting is then if you add cannabis with the SSRI and they play nicely in the sandbox together, or I should say they do play nicely in the sandbox together, and what you can do is you can bring back some of that joy of life and kind of undo the side effect of the SSRI itself. With regard to anxiety, cannabis can help anxiety and it can provoke anxiety. And for most people, that's a very dose-dependent process. So a little bit is helpful and a lot is counterproductive. Many folks that I meet, patients that I meet who come to me with anxiety come already using cannabis. And in many instances, they're using way too much cannabis and it really ends up sort of being in the way of their life. It turns out that, you know, if you ask in the cannabis community, you will find that most people with anxiety wake up in the morning and they smoke some cannabis and they keep smoking throughout the day. In certain very severe cases, that may be necessary, but in most cases, that's probably a harmful way of doing things, and that a low dose that would be vaporized prior to bedtime is not only sufficient, but the nice aspect is that the intoxication wears off sort of overnight, but the benefit is persistent throughout the next day. And many folks have come to me surprised by that remark, only to come back and say, you know, Doc, you were right, this is great, and then I don't have to be intoxicated throughout the day. Insomnia. Insomnia turns out to be the number 2 presenting complaint in the United States, and also the number 2 complaint where folks tell us that we're not doing a very good job again. And it turns out, of course, that we have a fairly limited number of medications that work. Certainly we can give people something like Benadryl, which sometimes makes people sleepy. And in younger, healthy people, Benadryl is modestly effective and relatively safe. But once we get into older folks, Benadryl has a tendency to make them fall down and break their hips. It also makes it hard for men to urinate. So that's not such a great choice. And then other options would be something like Ambien, which for some people is effective, but for other people they develop, hangovers the next day, which sort of talk them out of using it. And then we've got the benzodiazepines, which again can be helpful, but come with sort of a boatload of risk associated with the respiratory depression and dependence. I think that cannabis for insomnia turns out to be not only wonderful, I think it's a thing that it does best of all. And again, a very low dose, typically vaporized before bedtime, can be extraordinarily effective. Insomnia can come in a number of different forms, and we have to tailor the therapy to the particulars of any individual, but the success rate is very high. Anorexia. Anorexia in this context is the medical term we mean for can't eat. So I want to make the distinction between anorexia as a general term and anorexia nervosa, which is a mental health condition most closely associated with obsessive compulsive disorder. And while cannabis can be extraordinarily helpful for sort of generalized anorexia, it's been shown to be quite possibly counterproductive and harmful in anorexia nervosa. But for people with generalized difficulty eating, again, low dose, tailored doses of cannabis, throughout the day can provoke better eating. One of the things that's very interesting is people come to me sort of asking about sort of the opposite. It's like, well, if I'm using cannabis for whatever I've got going on, am I going to get fat? Because everybody worries about the munchies. And the answer to that is kind of interesting. First of all, I think that cannabis should always be used with mindfulness so that we're being careful and thoughtful about this. And so that leads us to thinking a little bit about the munchies and not sort of just deciding that we're going to ignore them and hope that they don't rear their head, because they will. But also in preparing the environment for the use and treatment with cannabis, I tell my patients to stock up with baby carrots. Why? Because the munchies are the triggering of not only an eating reflex, but a preference for crunchy items. So the classic is to grab a bag of Doritos, but we don't want to do that because I don't even know how many calories are in a bag of Doritos. So the idea is, if you're going to grab something, let's put the healthy things in our path and leave the Doritos in the supermarket. Nausea and vomiting is certainly the one that we kind of commonly associate with cannabis. There's been a long history of smoking cannabis sort of on the sly when people have been treated with the chemotherapies associated with cancer treatment. And it turns out that cannabis is fairly effective for this. As a result, in the late 80s and early 90s, the FDA actually went ahead and approved a medication called Marinol or Marinol for use with nausea and vomiting associated with chemotherapy. And the history of that is actually kind of interesting, because while Marinol was sort of effective in studies, most people who took it said that it made them so aggressively high or intoxicated that it was too unpleasant and they really didn't want to continue. And so that medicine sort of never caught on, complicated or bumped off the shelf by the fact that in the early 90s a medicine called ondansetron or Zofran came along, and that medication turned out to be actually better for nausea and vomiting than cannabis is. On the other hand, what's really interesting now that we've come back around to thinking about cannabis, in particular whole plant cannabis as opposed to synthetic THC, is that that it's not either or. So if you are that sick and the Zofran isn't working for you or isn't working enough, adding cannabis on top works really well to get the best mileage. Sexual dysfunction is an area where cannabis can be extraordinarily helpful. It is a topic that I could spend an entire hour on just by itself, so I'm not going to spend too much time on it here. But suffice to say that issues around sexuality will affect 40% of women over her lifetime and 30% of men over his lifetime, and that they are not adequately discussed in medicine or publicly, and that we have very little in the way of treatment. Obviously, we have the Viagra, Cialis stuff that works for men with erectile dysfunction, but that medicine does nothing for any of the other sorts of problems that men develop, and it doesn't touch women at all. And it turns out that cannabis can be used to help both men and women with multiple issues related to their sexuality. And just sort of the key thing to file away about this is that there's a bit more leeway for women in the dosing, but that for men to get best benefit, we need to be fairly cautious and specific about the dose. But in either case, we can get a lot of mileage. I think I will leave that subject there. Now we can talk a little bit about illnesses as opposed to symptoms and think a little bit about what we know around those. There are a number of neurologic issues where we're starting to see some concrete evidence of benefit. There's certainly we've seen people with multiple sclerosis where we've been able to demonstrate some decrease in pain and decrease in spasticity. We've also been able to show in Parkinson's disease not a decrease in tremor, but there are a number of symptoms associated with Parkinson's disease and the treatment of Parkinson's disease that actually are amenable to treatment with cannabis, often having to do with insomnia and anxiety, which are sort of not discussed, but are very much part of the constellation of Parkinsonism. There's some discussion about whether cannabis or some of the components of cannabis, particularly CBD, but probably even more so THCA, which is a precursor of THC, might actually have neuroprotective effects. And we really don't have any evidence for that in human beings at this time. That doesn't mean that we found negative. It just means that we haven't gotten to the point where we've done those studies. What we do see is in the mouse and rat model, and we just have to take that with a major grain of salt. In fact, we have to take it with enough of a grain of salt that fairly recently I posed the question to myself, what percentage of drugs that seem promising in animal models actually then fail in human beings? And I went looking for the answer to that, and I nearly fell out of my chair when I found it. It's a whopping 92% of medications fail in humans after looking promising in animals, leading many in the scientific community to wonder why we continue to do any animal studies at all. Certainly at a time in history, animals were the only way for us to do some of the research that we need to do before we try things out on human beings, and there's some discussion now that in fact there are newer ways of approaching it that would be more accurate. Autoimmune diseases are also something where we're starting to see some evidence. Crohn's disease is kind of the classic, and ulcerative colitis by extension. But rheumatoid arthritis is another one that's a big one that we're starting to see. And really, one of the things that we have to understand in this part of the discussion is that what we're really trying to accomplish here is not treat the symptoms, or not solely treat the symptoms, right? If we just were trying to treat pain associated with the inflammation in the gut or inflammation in the joint, that I think is fairly handily done with cannabis. The question really then is, can we use cannabis in a fashion that actually affects the disease itself? That is to say, treats the underlying problem. And we've started to see pretty good evidence of that in that inflammatory bowel disease. And we're even starting to see people kind of do that research in more traditional autoimmune diseases like rheumatoid arthritis. So more to come on that subject as we get more data. And then there's the whole question of treating cancer with cannabis. Again, symptoms related to cancer or symptoms related to the treatment of cancer, I think the answer is clearly pretty positive. The question of can we treat the underlying tumor with cannabis, and I think the answer to that is a resounding maybe, which is to say, again, we have a bunch of studies in animals, which really means mice and rats, and some studies in cell culture, meaning a test tube, that are very interesting and very provocative, that we can show that cannabis in either whole plant extracts or in specific components like THC or CBD can kill cancer cells. And in fact, we're learning that there's some specificity, meaning that not every type of cannabis is going to kill every kind of cancer, and that you're going to have to match the correct cannabis with the correct cancer, or at least by using these differences, we may be able to suss out what are sort of the more active ingredients that in the cannabis that we can then examine and learn from and perhaps manufacture and use in a more specific fashion. But again, all of that is very preliminary at this point. When patients come to me wanting to use cannabis specifically to try to address their tumor, really what we do is we have the discussion that we're starting to have now about how, it's a little premature. But then typically what I'll say to folks is, given the non-toxic nature of cannabis, as long as you are willing to promise me that you will continue your proven conventional treatment, then I'm willing to help you add this as an adjunct to that treatment. And I think that that's a fair compromise. But occasionally I do get people who want me to give them sort of my blessing to use cannabis instead of their conventional and proven treatment. And that's not someplace that I'm willing to go, because it's just, asking to die young. In fact, I had a young 42-year-old woman with a thyroid cancer that was entirely curable with a surgical procedure. She didn't need any medicine. She needed a surgical procedure, and she would have been done. She had 2 children under the age of 5 and a husband, and she was looking for me to tell her it was okay to just use cannabis. And I said I didn't think that was reasonable, and I've never heard from her again. I hope very much that she went back and got the treatment that she needed. And then the connective tissue disorders that we're obviously talking about this evening, I think that there's very little data on modifying the underlying pathologic process here. I think, frankly, we really haven't even started to scratch the surface of doing that research. And ultimately, or at this moment, we're far better thinking about symptom management with cannabis than we are thinking about sort of using this in some kind of underlying treatment manner. So this is my slide about strains and CBD. So what I'm going to say on this page is probably going to be heresy to some of you who may have some greater familiarity with cannabis. I don't mean to say that strains make no difference at all. What I do mean to say is that we have not been able to show significant differences in medical outcomes based on various strains. And some of that is probably because some of these strains are all jumbled up, and some of it is because the outcome differences may be subtle enough that we will only get to seeing them when we do very large studies with very controlled circumstances. But at least at the point that we are now, and based on my clinical experience, I don't find that the strain matters very much. Again, some patients definitely develop preferences for one thing over the other, but the preference is slightly different from medical outcomes. What I would say is that amongst my patients, I would say about 90% of people tell me they really can't tell the difference between one and the next. And then there's this other 10% that say, no, doc, it absolutely has to be this. And what I can't tell from that is that 10% group different biologically from the other 90%, or did they just drink the Kool-Aid? But I also see that the dispensary systems are often using strains as a way of selling patients more and different types of stuff, and I think that that's unfortunate and sort of abusive. Here's another hyperbolic statement. CBD, no proven value. Well, that's not fair. CBD has definitely been shown to be useful in treating kids with seizure disorders. But let me clarify that. These are not just kids with seizures. We have really good, compelling data on these children. But think about how many adjectives I'm about to throw at you. They're children with rare genetic seizure disorders, right? So these are a very tiny group of very specifically challenged children who have either what's called Dravet syndrome or Lennox-Gastaut syndrome. And these are children who typically have hundreds of seizures a day and really very poor quality of life despite the modern medical anti-epileptic drugs that are available. And when we give them CBD, it dramatically cuts their seizures. It can also, in some cases, even stop their seizures. And interestingly enough, it only works for about 6 months, and then the seizures come back unless you add back some THC into that mix. And so clearly there is some interplay going on between the CBD and our internal cannabinoids, and then needing of a boost from some external cannabinoids as well. So in some ways, I'm being hyperbolic when I say that CBD by itself is not helpful, but in some ways not, because in fact, once you've used the CBD for a little while, you really do need to add some THC. It's also important for us to understand that these children do not provide a reasonable model to generalize to anyone else, right? These children have rare genetic seizure disorders. They're not like other children who have unexplained seizures, what we call idiopathic seizures, and certainly have nothing in common with adults with sort of routine forms of epilepsy. And so we have to be a little bit cautious about sort of the desire to hyperbolize and generalize from what we do know beyond what we know. This is an interesting statement. There's some evidence that using higher CBD to THC ratios can be helpful to reduce side effects. This has particularly been shown in cases where patients have some form of mental health issues and or risk of psychotic disorders, that CBD may be protective. What's also interesting is that there is sort of a rumor out there that using higher CBD rather in conjunction with a THC will prevent you from getting high or intoxicated, and that's actually been shown to not be true. That CBD may provide some neuroprotective effect, but it does not change the intoxication. It's also worth noting that CBD, unlike most of the other cannabinoids, is metabolized in the liver by an enzyme that is responsible for metabolizing most of the other conventional medications. So CBD, in fact, is the part that will interact with other conventional medications and can do so in a very dangerous fashion depending upon what other medications may be taken. So where, in the people are saying things like, cannabis can't hurt you and all that sort of thing, that's not strictly true, particularly when it comes to CBD high dosing in patients who are actually very sick and therefore may be on other medications which are potentially dangerous in this interaction. Now, let's see. Click this button here. So I want to talk now a little bit about the routes of administration, or how we use cannabis, because one of the interesting things about cannabis is that there are many, many ways that we can use it, and it turns out that some are more effective than others, and it turns out that the outcome varies with how we use it. In other words, cannabis behaves differently depending on how we take it. So I always start to talk to people about smoking. I don't generally recommend smoking to anybody. I think that most of us in the medical profession would like to see smoke not happen. It is important to mention, however, that we do have about 25 years worth of data on chronic recreational cannabis smokers, and we have yet to see them develop the kinds of problems that we see with tobacco smoke, like emphysema or lung cancer. However, it's also worth mentioning that 25 years worth of data is a very long scientific study, but it's not long enough, because we know that people who smoke tobacco tend to get sick at 40 plus years worth of use. So 25 years is reassuring, but it isn't the end of the story. So in general, except for very short-term use, I recommend that we avoid smoking. But if you think about it, smoking is a form of inhalation. And medicines which are inhaled, or cannabis when inhaled, behaves in a particular manner that has a number of advantages. So when we inhale cannabis, it has fairly rapid onset. There is stuff on the web that says it's instant, and that's just baloney. It is definitely not instant. It is quick, but not instant. And so it really kicks in sort of 10 to 15 minutes. The point I'd like to make about it not being instant is that if you really expect that it's instant and it isn't, then in that 10 to 15 minute window, you can, inhale a heck of a lot of this stuff. And when it does hit you, you can be quite surprised by it. So, I advise my patients to take a fairly slow and metered approach to this until they're confident about where they want to end up. The other thing that's nice about the inhaled stuff is that it has a moderate duration of action, meaning that once it's working, in general, the intoxication aspect of it lasts for sort of 3 or 4 hours. In many instances, that's a really good length of time. If you have insomnia, and then having this wear off overnight is a great thing. If you have a migraine headache and you want to take this stuff and affect the headache, but then have it wear off after the headache is better, and then you can kind of go about your day, that's a good thing too. So in most instances, for treating symptoms, particularly pain, which is episodic as opposed to constant, inhalation is a really good way to approach them. So if we want to use inhalation, but we don't want to get into smoke, as we talked about, then a vaporizer is the thing that we want. And hopefully you guys can see my cursor circling this weird looking device in the upper middle of the page here. This is a device which is a cannabis flower vaporizer. And flower in this case means the flower of the plant, not like baking flour. So it's Flower, which is the part of the plant that we use medicinally. And so what you would do is you would get the dried cannabis flower or bud and grind it up, and then it goes inside this thing in a little bowl where it then is heated up to a temperature of about 350 degrees, which allows the medication to come off as a vapor that you would then inhale through this little straw here. But we're nowhere near burning anything, so there's no smoke involved. And this is, I think, a very ideal way to deal with it. Now, just below this device, we get into this little pen-shaped vaporizer that is becoming quite popular, and I will say that I don't recommend that for most folks. And the reasons for that are kind of varied, but there are a number of things you should know about them. The first is that one puff on this is about 4 times one puff on this, which means that it's very easy within one puff to get more than you really need or want. But the other aspect is that cannabis concentrates, which is what we really call the oil in this cartridge, are solids or semi-solids. And so in order for these devices to work, the cannabis needs to be thinned with some agent. And the agents that get used can be a range of things from polyethylene glycol or propylene glycol, which when heated turn into formaldehyde, which as you can imagine isn't very good for us. It can be terpenes, which are derived from cannabis, which I think have erroneously been felt to be safe. First of all, these are potentially biologically active compounds that are present in tiny amounts in cannabis, and certainly we have no experience with them at these higher doses that would be used when we are using to dilute the cannabis. But the other thing is that we know that terpenes, when they are heated to a certain temperature, turn into carcinogenic compounds called acrolein and metacrolein, which we'd like to avoid. So in general, despite these being inexpensive and sexy and discreet, I think that they're not really very safe or helpful for us, so I tend to suggest that people avoid those. So that's kind of inhalation in a nutshell, and then we can talk a little bit about stuff that we can take by mouth. And the issue, one of the things that's out there that I think is very much not the case is this idea that if people are averse to smoking, that's okay because you can just take an edible. And that really doesn't acknowledge the fact that edibles behave differently from inhaled medication. And so the edibles, it turns out, not surprisingly, they take longer to kick in. But the part that's really interesting is that for reasons that are very much unclear to us at the moment, the length of time varies from day to day even though it's the same medicine, the same person, and we really haven't figured out how to predict what's affecting that. So that one day it might kick in after an hour, but another day, the next day, it might kick in 2 hours. I had one patient report that it kicked in 8 hours later. He had given up on the effect at all, and it was the next morning, and he was driving down the street when it kicked in. And as you can imagine, that was quite surprising, and that's a pretty unusual set of phenomena. But the point is, if it's delayed and it's erratic, it becomes very difficult to use it in a predictable fashion. On the other hand, because of the metabolism of the cannabis in the liver, once it's being absorbed from the gut, there's actually a chemical transformation there, and what happens then is that it works for much longer, more like 8 to 12 hours as compared with the 3 to 4 hours that we talked about for the inhalation. So this can be an advantage in patients who have chronic, meaning constant 24/7 pain. Using the oral stuff acts more like a long-acting medicine, right? You can't necessarily predict when it's going to kick in, but if you use it sort of by the clock routinely, so it's always kind of there, then you get long, persistent coverage. But we also then have to balance that with the idea that it's coming with some level of intoxication, right? So the question becomes, when I'm sitting with a patient, if I had you slightly buzzed all the time, would you be better off than you are the way things are now? And the answer to that really informs whether this is the right approach for that patient. There are a few other forms in which one can take, or with which one can take cannabis. Tinctures are very, very popular. This is a liquid form of cannabis extract. And it comes with its own lore/baloney. Cannabis tinctures, particularly the oil-based ones, can be absorbed in the gut, but they are fairly poorly absorbed in the gut, actually. The general absorption rate of tinctures is half that of a well-made edible. So under those circumstances, the edible sort of wins. Furthermore, there is this idea that if you put the tincture under your tongue and hold it there, that it will be absorbed through your mouth and have a rapid onset and bypass the liver and all that sort of thing. And unfortunately, we've got really good studies to show that that just does not happen. And that in fact, if you give people, this is the nutshell of the study that was done is, they gave a group of volunteers a bunch of some sublingual tincture, and they said, guys, whenever you start to feel something, raise your hand. And so, a few minutes went by and people started raising their hands, and they drew blood from these people, and what they found in the blood was absolutely nothing, and simply demonstrating that if you put something under your tongue and you have a certain expectation of an outcome, you're likely to perceive that outcome, and the fancy word for that is placebo effect. And I'm not saying that the placebo effect doesn't exist. It absolutely exists. It's just different from and not equivalent to a true biological phenomena. Topical agents, creams, lotions, patches, that sort of thing. There's some pretty good dermatologic evidence for treating inflammatory illnesses like psoriasis and possibly even eczema using topical cannabis. There are a whopping something like 6 studies, good studies in the entire world. In fact, 3 of them I had to have translated from German in order to read them. So there's not a ton of data there, but what we do have data for is the fact that cannabinoids do not penetrate beyond the skin. So if you are wanting to rub a salve on your knee because you have arthritis, then that is not actually going to work. Those cannabinoids will not penetrate past the skin and into your knee, which sort of biologically speaking is very, very far from your skin. So why does it work when we rub something on our knee? Again, this is a placebo effect, and it's really very well demonstrated in the literature. The only problem here is that if you look at this little pot of cream that I'm circling, what that will cost you in the dispensary is something like $80. And do you know more good than a gallon of Lubriderm that you could get at your local pharmacy for $5? So at some point, as a clinician, I have to balance my patients' pocketbooks and sort of at least advise them that this is money probably down the drain for them. This is a slide that we're not going to spend a ton of time on, but what I really want to get out of this or present to you is this idea that certification is not the goal. We don't generally go to our primary care practitioner and say, I think I might have high blood pressure and I want you to give me amlodipine or lisinopril. We tend to go to our doctors and say, I think there might be something wrong. Can you help me figure out what it is and what we should do about it? And very much in our society at the moment, we've put sort of the cart before the horse when it comes to cannabis, focusing on getting our certification, getting our card, and ultimately that leads to bad medical care. And good medical care is focused on patients and their needs and developing care plans that help them achieve their goals. And so I always say it's about the care, not the card. And that an important aspect of appropriate medical care is frequent follow-up visits. If a doctor out there, and there are doctors out there who are doing this, are sort of handing out cards and saying, so long, I'll see you in a year when I can collect $200 from you again and give you another card, that's not medical care, and I would run quickly from anyone doing that. Somebody who is going to sit down with you and talk to you about your illness and figure out with you how to best implement cannabis care strategy and then follow up with you with face-to-face visits or telemedicine visits or email or telephone or any of those sorts of things where there's some ongoing communication and guidance. That's what I think it's all about. Now we're into the summary slide. So I'm just going to click through this briefly. And what we can say is, look, cannabis has been maligned for a very long time, that the prohibition against cannabis was largely financial and political. We have great safety data on long-term use of cannabis. We also have great evidence at this point for its effectiveness for pain control, which is to say that it is effective for pain, not better than opiates, but equal to opiates and a whole lot safer. We've seen the beginnings of some effectiveness for neurologic and immune diseases. More to come on that subject, to be sure, particularly as we try to modify the underlying disease more so than just treating those symptoms. Key takeaway home here is that the route of administration really makes a difference to how this is going to behave for us, and that picking the right route of administration, which, by the way, I should mention, sometimes it's a combination of multiple routes to achieve the desired outcome. But in any case, we have to do this in a thoughtful manner, and we need to do it in light of people's, daily goals, such that we provide the best relief with a minimal intrusion. Whoops. Really? There was one last point there before we got to my happy veteran. And it really was not to get overwhelmingly focused on the strains, because, in fact, that seems to be far more about marketing than it seems to be about medical outcomes. So one of the things I wanted to provide you with is a bunch of medical references. I know they're going to put this link up on their website as well, but if you want to copy this down or take a screenshot, this bit.ly link will lead you to to a document that contains about 40 references, and if you want to explore further, that's a place to start. I would also point out that my practice is called Inhale MD, and the website here is inhalemd.com. And in particular, I've got over 100 articles on the website that talk about, a little deeper on sort of all of these facets, so that's a very good place for you guys to head if you want to dig a little deeper. And then here is my email address, doc@inhalemd.com. and I welcome you guys to send me questions or concerns as you see fit. And so that really is the end of what it is I wanted to say to you guys today. Thank you very much for your attention. I see that we have a ton of questions waiting for me, and so I am going to open up the question bin here and see what we got. Give
Thanks,
me just
Dr.
a second.
Tishler. Great. You can go ahead and open the Q&A. I believe there's about 25 questions there so far, and we'll just see how far we can get in the remaining time we have.
Yes, and how much time is that? I mean, a little over half hour, something like that?
Yeah, about half hour, 40 minutes, somewhere in that range.
Great. This is a great question. It's about 6 questions, so let me see if I can parse them and answer them a little bit. So the first part is, are there any age restrictions that I think are appropriate for waiting to use THC? Yeah, probably. I mean, I'm going to hedge a little bit on this. We've got some studies on the use of cannabis in particular, so not THC specifically, in teenagers, showing that over the course of the teen years when people use cannabis, there can be some changes that are evident on MRI studies. That's primarily what we know from a sort of concrete standpoint. The problem with those studies, as I see it, is that while we can demonstrate changes, it doesn't necessarily mean that we know what those changes mean, right? I mean, in some ways, my glib answer is, okay, now we see that these teenagers have changes to their brain. How do we know that we're not making them into X-Men, right? The fact that there's a change there doesn't necessarily mean that it's good, bad, or indifferent. When we look at addressing this from a different point of view, which I think is a more valid one, when we look at long-term recreational users who started as teenagers and follow them into their 30s and 40s and ask the question, are these people capable of functioning in society, meaning they can hold a job, they have relationships, and they're sort of upstanding functional members of our society? The answer is clearly yes. And we have, 40, 50 years worth of data on that. So back to the question, should we be using this in teenagers? I think the best answer at the moment is not if we don't need it. So if that teenager is so severely affected that, that they really need this kind of compassionate relief and that possibly their life expectancy or cognitive function expectancies are limited to begin with, then I wouldn't withhold these sorts of things. On the other hand, if I had, a 16-year-old who came to me and said, I feel a little anxious around my exam, should I smoke some weed? I think the answer would be no. Next part of this question was, for people with genomic profiles that indicate that they should only use a little bit of THC, are there strains that I would recommend? I think that, I've looked fairly carefully at some of these genetic testing profiles, and quite frankly, I think we don't really know what they mean yet. So there's more to be gained there. I think that, we've got an awful lot of desire to be able to do tests and come to a conclusion about it. And at this point, we have tests that probably mean something, but I don't think we've validated what they mean beyond sort of our hypothesis of what that gene locus is doing. So I would tend to be a little cautious about putting too much stock in those kinds of tests now. I really would like to get to using them, but I think the question is really, it gives you the sense that you have an answer when in fact you may have more of an observation than an answer. Can CBD alone be used for pain or sleep? That's a very good question. In fact, what we know is that when it comes to pain relief, THC is really it. And CBD is not really a pain reliever, but it is an anti-inflammatory. Now, comparatively to some other things like prednisone, it's not a very good anti-inflammatory, but it may be one that has fewer long-term consequences. It's also interesting to see that there's starting to be a literature around THCA, which I mentioned earlier, and it's probably even better as an anti-inflammatory than CBD is, and also doesn't come with the risks associated with drug interactions that CBD has. So in general, if we're treating pain, I would point us more towards THC. Another thing that's very interesting is that somehow people have started talking about CBD for sleep. CBD is associated with wakefulness, not sleepiness. So in fact, using CBD for sleep would probably be counterproductive. Okay, this is an interesting question. At what THC and CBD level does psychoactivity begin to occur, and what dose keeps it under the psychoactivity but enough THC to address deep bone pain? I think that's a very reasonable question. I just don't think that's one that we can answer. The psychoactivity begins based on the THC level, and that varies from person to person within a sort of narrow range. Generally, it's felt that somewhere around 5 milligrams is something that people start to notice, and below that we kind of get into microdosing where it's less, that there may be some psychoactivity, but it's more subtle. Then the question is, at what level of THC would we expect really good pain control? And the answer is above that, meaning sort of more in the 10 to 20 milligram range. And again, adding the CBD doesn't really decrease that psychoactivity. So that part of the question is I think, more wishful thinking than reality. So what I'm really getting out of this is, how can I take care of my bone pain without getting intoxicated? And the answer really is not happening very easily, because it is in fact the THC that's going to give you both the intoxication and the relief, which gets me back to that idea that the intoxication for patients is really a side effect, and that we need to manage that much more than hope that it doesn't exist. Do I suggest taking breaks to get your tolerance back down? No, I don't. And the reason for that is twofold. One is that I think that, the idea of a tolerance break, which does work, by the way, really comes out of the recreational user's experience. And, if you're a recreational user and you want to save money or whatever, and so you want to bring your tolerance down, the idea of taking a break makes perfect sense. But for most of my patients who are so ill, the idea that they should take a break for a week or two every once in a while really kind of flies in the face of trying to get medical relief. And furthermore, we know that when we withdraw pain relief, for example, not having to do with withdrawal of the substance, but just say, we're going to take this break, the pain tends to get out of hand and actually becomes sort of a cyclical revving up, and that would be something we'd like to avoid. What I think is a better approach to this issue is to use very low and careful and consistent doses, because if you're using sort of 10, 15, maybe 20 milligrams, once or a few times over the course of the day, we tend not to develop the kind of tolerance that we see in the recreational community when they're using, an order of magnitude more than what I just described. And so, again, low, consistent doses, and we seem to solve that problem. Would taking CBD without THC for pain leave me at risk of becoming addicted? I don't think there's any literature to suggest that CBD by itself produces dependence at all. But I also think that we probably haven't studied that very closely either. What I would also say is that I think it's very unlikely that taking a purified CBD product is likely to significantly affect that pain. So that's sort of great difficulty with consistency of dispensaries. I'm having a little trouble figuring out how to respond to this question. I think I sort of have made the point already that I think that very highly purified CBD is less likely to be helpful to most people who are in pain. That's, I think, about what I have to say on that subject. Why is this popping in my face here? Hang on a second. So this question is about people who sort of develop the lack of motivation when they use cannabis. And there have been some studies on this in the psychology literature, and they're all over the map. And basically what I have come away with is that there's a lot of discussion and worry about a motivational state, but there's really very little evidence to support that it actually exists. That being said, I don't doubt that there are plenty of stoner slackers out there who may very well kind of be the genesis of this idea. But there are plenty of other people who are stoners who are not slackers, Steve Jobs and Carl Sagan, as, a couple of counterexamples. Again, thinking back to sort of the question and the particulars for EDS folks, I don't think that there's any significant concern for you guys around that, and that the best evidence looking again at long-term users, meaning over 30 to 40 to 50 years, doesn't seem to show any degradation of life outcomes, including educational level and job attainment and salary and that sort of thing. So I think I wouldn't worry about that. This is a question. When I talk about cannabis, do I mean CBD with THC or just CBC? I think she meant CBD. And the short is, when I talk about cannabis, what I really mean is the whole flower-based plant derivative. So whole plant or whole plant extract, which would contain THC or THCA, as well as a small amount of CBD. And what we really understand is that these cannabinoids work together. This is a theory called the entourage effect, which basically says, look, the THC is kind of the rock star, but we know that THC doesn't work very well by itself, and that there are a whole host of other cannabinoids, of which CBD is one, and they work synergistically, or at least in cooperation, to get us the effect that we're looking for. How does cannabis work for depression, and isn't it a depressant itself? The how does it work is still a little bit of a mystery, but we are in fact starting to understand its molecular biological mechanism. And it's actually very interesting because it is forcing us to think about some of these psychological illnesses in a different way as we start to connect the psychological components to their biological underpinnings. And so, in fact, there was an article that came out a few weeks ago that looked at unipolar depression and its interaction with the endocannabinoid system. And what they found was that, in fact, that people with unipolar depression had an excess of a particular series of amino acids in the proteins that were associated with the cannabinoid receptors. And that was seen in the depressed patients. But what we also found in the same study was that in absence of that set of proteins or amino acids leads not to mania, but actually to schizophrenia. And so that may be that these two things are actually related to each other biochemically in ways that we never thought they were related to each other. So to your question isn't it a depressant itself? I think the answer is very clearly in high doses, yes, it can be a depressant. But in low doses, where you're using it at the right threshold to increase the signaling, then it's not a depressant, an antidepressant. You know, I think that a really important concept here is this idea that just like any conventional medication, there's sort of a bell-shaped distribution of when and how this works. Meaning, if you start with 0 and you start increasing the dose, you get to a point at the peak of this bell shape where you're getting the best benefit, right, at that dose. And then beyond that dose, it starts to slope back downwards because, in fact, now you've gone past the point of best benefit and you're starting to take enough that you're starting to get some of those more side effects and negative outcomes. So dosing is really key, is what I'm trying to get at. So this is a question about a particular person's father who was using a lot of cannabis. It sounds like sort of maybe that was more recreationally, but now he's developed some back pain and the cannabis isn't helping him as much as the opioids are. And is this because he needs a different strain or he needs to be more CBD? I think the problem here is that if he has flattened his endocannabinoid system with high doses of cannabis, he's going to need a whole heck of a lot more cannabis to get the relief that he's looking for. Or, alternatively, he needs to slowly taper the cannabis back into the range where you're in that sweet spot so that those receptors can recover and start to respond appropriately to the amount of THC and other cannabinoids that he would get from the cannabis that he's using. So there's definitely such thing as too much cannabis, and when we use too much of it, we kind of just shut off that receptor pathway, and I think that's probably what's going on with this gentleman. Somebody asks, what are some safe concentrates to try to make at home? So let me start with, in general, I don't recommend that people use concentrates because delivery of concentrates in a very low and consistent dosing fashion is very, very difficult. Concentrates do make a very good intermediate step for edibles, but you also have to remember that cannabinoids are intensely hydrophobic, meaning they really don't get along well with water, and most substances that you would bake with as well as ingest are in fact mostly, if not entirely, based in water. so that getting edibles, homemade edibles, to be consistent and reliable is a huge bugaboo. If you're really insistent on trying this at home, please do not use butane because the chances are you will blow you and yourself and your house up. You can use alcohol, ethanol, which in some states you can buy in the liquor store, and that can make a reasonable concentrate, although it tends to be fairly dirty, meaning it tends to have a lot of other plant material in it, particularly chlorophyll, which makes it ugly, but also makes it taste bad, and plant waxes, which are not very good for you to inhale. In fact, they're really very bad for you to inhale, so that I would advise not using it in that way. Have I seen CBD oil creating muscle cramping, and does this happen with cannabis? I have not seen CBD oil create muscle cramps, and I think the answer is no. Cannabis should not be causing muscle cramps at all. In fact, all the data that we have, particularly from the MS population, shows that cannabis would do the opposite and treat muscle cramps. This is a particularly EDS-centric question, which obviously is sort of the point. And the question is, are there studies of cannabis in patients with mast cell activation disorder? And unfortunately, at this point, the answer is really no. We are obviously trying to progress towards a greater understanding of cannabis, and it's sort of just a matter of time until we get to answering all of those questions. But that one just hasn't hit the top of the bucket list yet, I'm afraid. All right. What is the most effective cannabis for nerve pain and headaches, and what is the best form for EDS, since a lot of topicals don't work on us? Well, at least in this case, topicals of cannabis are unlikely to do much anyhow. I think that, again, the method of ingestion here is more about kind of the chronicity of the pain, so that if one has ongoing nerve pain that is sort of 24/7, then I would probably be focusing on an edible. And she mentions oil. Again, oils are pretty poorly absorbed, so there is actually sort of some evidence that, a lot of evidence actually, that edibles are more effective, so I would tend to point that direction. Now, don't get me wrong. When I talk about edibles, I'm not saying go and eat 2 pot brownies every day. You know, I say take 2 brownies and call me in the morning is not practicing good medicine. Obviously, one of the things that we like to talk about is practicing holistic medicine, and oddly enough, somehow in the cannabis world, that doesn't usually tend to be true. It is important for us to remember that we're not just a need for cannabis, and that many of us are, many Americans are overweight or diabetic or those sorts of things. And so introducing an extra 250-calorie brownie twice a day is probably not practicing good medicine. On the other hand, a small gummy cube that has 30 calories in it once or twice a day seems much more reasonable and is equally effective to that enormous brownie. Again, she mentions headache. For episodic headaches, vaporized cannabis would clearly be the way to go, because it will work when the headache happens, and it tends to wear off, you know, not too long after that when the headache has gone. This poor lady asks sort of the million-dollar question. I'm going to read, none of my doctors know anything. Boy, I hope they don't know absolutely nothing. But the cannabis doctors here just approve licenses. Shame on them. How do we get dosing information? I've been able to get zero help except from the anecdotes from the dispensary staff. First of all, let me say that I'm sorry that this is the current state of things, and as you can see from our discussion tonight and my, my founding of the now International Association of Cannabis Specialists, I'm working very hard to change this situation. It's certainly not going to happen overnight. Cannabis doctors that are just approving licenses should be smacked. Not literally. How do we get dosing information? I think at the moment I would say start with going to my website and reading some of those articles because they're actually there to be helpful. And the reason I wrote them is so that people can get something out of it. And, you're right. Dispensary is a very bad place to get information. Most of the folks behind the counter, their level of understanding of cannabis is, yeah, dude, I smoke weed too. That obviously doesn't get us very far when we want to talk about things like dosing and precision and clinical experience. The other thing is that I will suggest that, if you've done the homework and you still have questions, email me, and if you want, we can do an online consultation where we can focus, more specifically on what it is that you need. Will I be discussing delivery mode? Yes, I think I did that. Using some vaping devices that are unregulated and whose safety is variable. Yes, there have been some vaporizers that have been shown to be quite unreliable, and some of them actually even burn the cannabis, even though they say they're vaporizers. There have been reports of measurements of volatile organic compounds coming from the vaporizers themselves, which is why I tend to recommend some fairly specific vaporizers because, as I say, many of them are cheap and junk. And in fact, some of them are very expensive junk. So in my practice, I have examined or vetted about 3 dozen machines, and there are 2 that I recommend to people. I think that that's been my way to respond to that issue. The 2 that I tend to recommend are the Storz & Bickel Crafty, which is the one that you saw a photo on my slide. And that is a really excellent machine. But it costs $279. So there is a slightly cheaper version, or alternative called the Boundless CFX, and that's $169. It's a little bigger and a little less user-friendly, but it's equally effective for getting a medicine. And I'll tell you, I continue to do my homework on this when new devices come out, and I'm so far not super impressed that we're moving the ball down the field particularly well. That being said, I am involved, because this is a subject near and dear to my heart, with no less than 3 companies that are working on metered dose inhalers, or metered dose vaporizers, meaning devices that you will actually be able to get a specific dose out of them. Most of them are not to market. The one that is closest to market is from a company called Cannacorp, and they manufacture a process called the WISP, which uses a pod-based system, kind of like the Keurig coffee system, and they're just sort of getting to market now. So they're not really available to you guys yet, but they will be over the next few months. And then there's another company called Podbotics and another company called GoFire, and those guys are still in R&D, but also closing in on being available, and I think that will, in fact, move the ball down the field. Why did they do this to me? They warned me about this, and now the question was about cardiac effects. And what we know is pretty up in the air at the moment. We have some evidence that cannabis can provoke a particular cardiac rhythm called atrial fibrillation, and that is something where on occasion it can be a problem for some people. But beyond that, we have not seen a ton of really solid data showing that cannabis presents cardiac problems. The question really stems from this question of dysautonomia and POTS, and I have a number of patients in my practice who have POTS, and I would say that the majority of those folks find that cannabis is actually helpful for their POTS syndrome, but it's certainly not 100%. And my best take on this is to be worried about it and to approach it in a very, very cautious fashion and see where this works out for you. But again, this gets right back into this idea that cannabis care should not be simply giving you a license and saying, go figure it out. It's the kind of thing where I would suggest a particular regimen to my patient and then follow up closely with them by phone or email or something over in a few weeks of trying this and seeing how people react to it before we kind of come to any conclusion about that. Could it be possible that having connective tissue disorder would enable a topical to differently penetrate to deeper tissues? I think that that's not something where I could say definitively no, but I don't see any particular reason to think that that would make a difference. I certainly don't think that that would be something that would make me put aside the idea of placebo being the majority effect. Is there data or are there data on the using cannabis to attenuate withdrawal from opioids? There's a lot of anecdotal discussion about this, and there have been some treatment programs put in place. There's one called High Sobriety, which I know very little about, except that I know one of their advisors, who I think is a very smart person. They're based in LA. There's a group in, and so I think that that group is probably doing a reasonable and responsible job. There is a group in Maine which basically takes veterans out in the woods and gets them so blitzed that they can't possibly notice that they're withdrawing from their opiates, and I suspect that that's probably a less good and less responsible way of doing it. But in terms of actual studies looking at whether this works and whether it's sort of a good approach, I don't think we have that just yet. It's very much on people's mind, and I would bet money on the fact that those studies are ongoing now, but they just haven't been ongoing long enough for us to have reports of results. Please direct us to a national list of doctors who can help with cannabis dosing and follow-up. I'm working on that, to be sure. On the website for the Association of Cannabis Specialists that I keep talking about, we have such a thing. The only problem is that it's not very full yet because we have only been at this for a little while. So if you guys really need help in the meantime, I think the best answer would be to contact me. But that being said, know that this resource is being compiled. And while I'm thinking of it, let me give you that URL. The URL for the Association of Cannabis Specialists is cannabis-specialist.org. Again, cannabis-specialist.org. So hopefully, as over the next few months, we're going to be developing that as a better resource than it is at the moment. All right. Somebody is asking me, for chronic daily pain, do I suggest THC pill, topical, or vape? and that her state does not currently allow flower. Each of the states has done an interesting job with their regulations, and I think many states have gotten sort of a piece of the equation right and then blown the rest of it. We don't have any state, I think, that has come close to the way this ought to look. And again, through the Association of Cannabis Specialists, we're trying to a rubric or federal regulation that would sort of encompass the greatest hits from all of these state experiments. So under the circumstances, I think THC pills would be, twice a day would be a good baseline approach to the pain control. I think that the salve is probably not worth your time and money, and that the THC vape would be useful when the pain sort of exceeds the level of control that is achieved with the pills. And so that kind of a mixed approach or bimodal approach tends to be very effective for people. Are there any studies available to join? I don't think I can answer that, unfortunately. I'm sure there are, but I don't know how to direct you to sort of a clearinghouse for how to find those sorts of things. This is a really interesting question. Do I suggest getting lab results from the lab or farm that you're buying from in order to rule out harmful substances? And if so, are there specific things to look for in the results? Unfortunately, again, states are regulating this stuff on their own. Some states are doing better than others. Arizona doesn't currently mandate any testing at all. Colorado mandates testing in the recreational market that somehow doesn't apply to the medical market. Here in Massachusetts, it's all going to be tested up to the medical standard, which is fairly stringent and appropriate. I would absolutely want lab results, and better, most importantly, they should be from an independent third-party lab so that there's no, shenanigans going on. And what are we looking for? We want a series of things. We want to understand what the cannabinoid profile is, and we want to know also possibly about the terpene profile, which is a different set of chemicals that are involved in the effects of cannabis. But then obviously when it comes to contaminants, we want heavy metals, because cannabis can absorb heavy metals and concentrate heavy metals from the soil in which it's grown. We want to know that there were no harmful pesticides that were involved in the treating, and then we want to know that that it's not growing mold. I mean, a lot of the testing looks at all kinds of stuff like bacteria levels, like E. coli and stuff like that. Since we're going to cook the cannabis either in the process of making it out of the process of vaporizing or whatever. Otherwise, I don't worry that much about bacteria, but mold, particularly one called aspergillus, is one that I worry about a lot, and that really should be tested for. We are running short on time, so I'm going to skim through this. So this is a question about treating gastroparesis and what strain or method is best. Unfortunately, cannabis can actually exacerbate gastroparesis. So if gastroparesis is a major part of your symptomatology, then we may need to think twice about using cannabis at all. And thankfully, again, this is fairly non-toxic, so it may be a thing where we can try it, and at low doses you get some benefit. But it is unfortunately a reality that while cannabis is generally beneficial for most gut issues, gastroparesis is not one of them. I've heard about layering different methods. Is this really the best way? Yes, again, depending upon the chronicity of the pain. Question about affording all of this stuff. I'm afraid that where we are with this is in a complicated position. It is true that cannabis is expensive, and so is going to see the doctor. And unfortunately, the doctor part of it can be covered by insurance, but the medicine part of it, not at all at this point. So many dispensaries have some sort of discount that can be either not very significant or can be significant. Some states like Massachusetts mandate some kind of accommodation for people. And it is kind of ironic to me, particularly in light of the opiate epidemic that we're facing, that the insurance companies are still happy to provide for the opiates. And it turns out that the opiates sort of in general are significantly more expensive to the insurance company than cannabis would be, but then all the politics happen sort of where we are. In the ACS, we have a committee devoted toward these issues around insurance, but, you know, it's just beginning to sort of enter the discussion. In Canada, the Sun Life insurance company recently, meaning in the last maybe 3 or 4 weeks, made an announcement that they're going to start covering cannabis as medicine. That is, to my knowledge, the first major insurance company coming out with that kind of a statement, though there have been some minor things around workers' comp and stuff here in the United States. Of course, Canada is a separate country from the United States, so what happens there may not sort of directly or immediately influence the United States. We can just hope and cross our fingers that that starts a ball rolling that eventually will pick up some speed. Do I do online care? The answer is yes, I will do online stuff. Obviously, I can't write for cannabis in certain jurisdictions. I can write in Massachusetts and in Rhode Island and Vermont, of all odd things. But beyond that, I really have to be limited to educational interventions. But obviously, I'm more than happy to do that and try to help in any way that I can. Somebody asked me about her mother, who's a doctor at UCLA, and could she get in touch with me? And the answer is, of course. I would absolutely adore that. And then somebody asked, what is cannabis oil exactly? I think this isn't a bad place for us to sort of end things. Let me just simply say oil is a word that I dislike because, in fact, none of this cannabis stuff is actually oil unless somebody has added oil to it. Really, these extracts are esters and waxes and not oils. Oil is used in this context to mean any sort of goopy or syrupy material, and then can also be used to describe something one takes orally or one takes by vaporization. At the end of the day, what we're really talking about is a highly concentrated puddle of cannabinoid compounds, and what's in that depends on what the starting material was and what the extraction process was and how well it was done. And so, in some ways, I think you've heard me say over and over this evening that I prefer to have people using whole plant flower, and part of that is because it's less likely to be adulterated through the process of human intervention. At the bottom line, and then there's the issues about concentrates in general being very difficult to dose. So in most instances, while cannabis oil, with heavy quotes around the word oil, is sort of caught on in the national press and conversation, it's not something that I actually tend to recommend to folks very often. I think that's the end of the questions here.
Okay. I had one more question.
Oh, good.
Oh, I'm sorry. I had one more question verbally I wanted to ask you on behalf of some of the patients that are in my local support group. I don't know if this was specifically addressed. They wanted to know if a patient is currently taking a prescribed extended release opioid, probably for several years, and wants to switch to medical cannabis. do they need to slowly titrate off of the opioid first, or will they go through a detox period, or can immediate transition be made from the opioid over to the cannabis?
Okay, that's a great question with many embedded questions, so let me see if I can parse this a little bit. The first I would say is cannabis and opioid play well in the sandbox. There's no contraindication to either one from the other. Cannabis actually, the use of cannabis with opioids does not increase your risk from the opioids, and in fact, because they work synergistically with each other, what we have found is that you can typically reduce the opioid dose to about 20% of the previous dose when you add cannabis. Now, that all being so, and also that one's risk from opioids is linear, meaning the more you take, the more you have risk, and the less you take, the safer you are. That all being said, I think we've gotten into a pretty unfortunate and weird place where we've now decided that nobody should be on opioids for anything, and that's just not fair or accurate. Opioids are a very important class of medication that do come with some risk, but used carefully and appropriately, we should not be throwing out the baby with the bathwater. What's nice is that by using these two things together, we can use less of the opioids and therefore decrease the risk. I get lots of patients and people asking me about using cannabis to get off a pharmaceutical, and I think that that's unfortunately not a very good way to look at things. In most instances, there's not a compelling reason to get off something if it's giving benefit. If it's not giving benefit, that's a different discussion. And if there's risk associated, then it's not necessarily that we want to get off it, but we want to reduce it while maintaining the benefits. And that's, again, when the opiates and the cannabis play well together. What I typically say to my patients is, let's not focus on the getting off. Getting off is an inherently sort of negative and stigmatized point of view. This is bad, I got to get away from it kind of thing. And I think that puts a lot of pressure on the system in ways that can be very harmful. And so what I prefer to try to coach people towards is thinking, let's use these medicines to help you get the best benefit. So if we're talking about pain control, let's use cannabis to achieve the best pain control we can. And in doing so, and in prioritizing the cannabis over the opioids, what we tend to find is that just sort of naturally and slowly over time, the opioids become less necessary, less important, and they just sort of fade away or fade down, and it becomes much more of a positive outcome than this sort of pressure of I need to remove these things and it needs to happen soon. So that I found just to be a much more successful approach to the whole thing. And it also tends then to allow us the freedom to land in a place where the cannabis works, and we may still need some opioids, but they're less, and that's good for safety, but we haven't gotten into this mind frame where we just have to reject the notion altogether and then cut ourselves out of the treatments that we need.
Great. Thank you so much.
My pleasure.
I think that
people ask really good questions. I really appreciate that.
Super. Well, we really enjoyed your presentation tonight. Thank you so much for spending your time and sharing your expertise with us. And we welcome you back if you want to do any follow-ups in the future. And
Absolutely.
All the live attendees
I'll be there.
Okay, super. The live attendees are really appreciative. They had a lot of questions for you, and they learned a lot. And again, thank you everybody for attending, and thank you, Dr. Tishler, for helping us out tonight.
Thank you. My pleasure to be here. And any questions or whatever, I'm readily available. So please don't hesitate to reach out.
Okay. Thank you. So kind.
Yeah, great, Dr. Tishler. I thought that was very informative and also allowed us to learn more about the practical aspects of the cannabis. Many of us are starting to understand and needing to understand how that will help us in the future. So we appreciate your webinar. We'll be posting that on our site along with the URLs, the links that you provided. And I'd like to remind people that these are programs that we do monthly, and we have a couple more scheduled for the next couple months. And this was a very popular one that has been recommended a number of times by our members. So please look at our site. Also, the new physician training program. Please promote that. And our programs are sponsored by Body Sports Store, where we have about 250 products that help people that have these types of disorders. And we appreciate you going in. That's what helps fund these programs. So, again, thank you, Doctor. Thank you, Deanna, and all those who attended. And we'll be seeing you next month. So have a good evening.
Thank you, everyone, for joining us. Just a little teaser for some of the future webinar topics. We do have a topic next month on dysautonomia. We also have Dr. Bolognese coming to talk about neurosurgery, Chiari, et cetera. And then we have pediatric psychologists that will be joining us. So those are the next few months coming up. If you want to sign up for announcements, feel free to go to our homepage and click on the receive the free guide and webinar announcements, and you can be on our email list, so you'll be the first to receive the registration information to register for future free sessions. And also, please remember to inform your physicians as you go to your upcoming appointments that we have free CME credits for them on our website with the Ehlers-Danlos and Associated Conditions educational program, and that URL is ehlers-danlos-cme.org. So feel free to visit that and print out the brochures and information for your physicians to spread the word and improve patient care. Thank you, everybody, for attending tonight, and we look forward to seeing you next time. Good evening.